to talk to you about an interesting case in hyperbaric medicine, and this would be about an adverse event in inside attendant. As you know, we have with multi-place chamber, we'll have staff inside to take care of the patient. So in our center, we can have up to 10 patients in the main lock of our chamber. So we will have inside attendants to take care of those patients. So on that day, one of the inside attendant was a 44 years old male respiratory therapist who had a great experience with 275 respiration inside the chamber. Was in good health condition. It was taking only a medication for a gastroesophageal reflux disease. He's a non-smoker. So on that day, on December 8, 2017, he was inside the chamber to take care of the patients for elective treatment. A second inside attendant was also in the chamber. The respiration was at 2.4 ATAs for a total time of 100 minutes. And the decompression pattern was oxygen for the last 15 minutes of the third period of oxygen, and then the ascent. So we're giving more than what we would have minimally to give, because for the same exposure, the CIEM tables with in-water oxygen decompression table calls for 5 minutes at 30 feet on oxygen. So we're giving 15 minutes at 45 feet, and then oxygen for the 8 or to 10 minutes it takes to get the chamber to the surface. So the treatment went uneventful. The inside attendant exited the chamber around 9:30 a.m. This was his only exposure of the week, and he had not been doing any scuba diving during this week. He reported to have done some physical efforts the day before, doing some home renovation. So what were his symptoms? About 30 minutes after exiting the chamber, he feels a vague pain of low intensity in the anterior portion of the left thigh. The pain continues during the rest of the day. He did not report to the medical director or any other colleagues on the hyperbaric medicine unit. He did not remember any physical effort while taking care of the patient inside the chamber. He had no thoracic pain, no breathing difficulty, and no neurological symptoms. So at the end of the day, at about 5 p.m., the pain intensifies. It's now at 6 out of 10 on the scale, pain scale. He was supposed to celebrate his birthday on that date, so he took acetaminophen and decided to get some rest. And about 8:30, he finally decides to call the hyperbaric physicians because the pain was worsening. And while he was going down the stairs, he felt less control of the left lower limb and less strength in that limb. Physical exam, blood pressure was a little bit elevated. The rest of the vital signs were okay. The patient was oriented. We could not see any skin rash that we could see with decompression sickness. Cardiopulmonary examination was normal, and limb strength was okay on examination. So we decided to put the inside attendant inside the chamber now as a patient, and to treat this inside attendant with the U.S. Navy Table 6, because we're facing a pain after a hyperbaric exposure. The decompression sickness was the diagnosis that we need to clear. So putting the patient in the chamber and see how it will respond was the idea. So after the first period of oxygen, so we're at 18 meters or 60 feet equivalent of pressure. We're breathing 100% oxygen. 90% of the pain was gone. And after the second period of oxygen, a quasi complete resolution of the pain was noticed. And at the end of the treatment, no residual pain. So why this happened? So was there a problem with our worker? Was there any predisposing factor that would put our worker more at risk for DCS? And or was there any technical problem with the planned decompression? So we first look at our patient. We ordered a transthoracic echocardiogram with infused bubbles just to detect if there was any patent foramen ovale. And there were no signs of PFO with this inside attendant. So it was decided that the inside attendant should be off for at least 1 month of any hyperbaric exposure. And so then we decided to look at the technical part. So the technical investigation was, so was there a problem with the operator of the chamber or the machine? So was this a human error? Did the chamber operator forgot to make the switch to oxygen on the supply line at the beginning of the decompression? So we checked with the chamber operator, and was sure that he swore to us that he made the switch to oxygen. He could not have forgotten this step in the process. So the next step was to look at a possible technical problem. So was there a problem with the chamber itself about the gas supply for the decompression procedure? So our usual procedure with the chamber was to do gas analysis on each gas supply line every morning with the opening of the chamber. In our routine, we did not check the gas analysis after we made the switch to oxygen. So this is a diagram of all the gas supply lines to the chambers, and that's how we can check what's really in the gas line. So after this accident, we decided to analyze the built-in breathing system line every time the patient and inside attendants are switched to oxygen to make sure that it's really oxygen in the line. So what we found that on rare occasion, we noticed that the oxygen percentage was not near 100% as it should be on the bibs when we were supposed to be on oxygen. So it was later discovered by our safety director that the emergency air valve was a problem. So the role of this emergency air valve is to automatically supply air into the bibs line instead of oxygen when the fire suppression system is activated. So this valve was leaking, was partially opening, and so air was mixing with oxygen at some occasions. So this is this emergency air valve, and so it supplies the bibs supply the bibs selection block that will give the gas supply to every line in the chamber. So the valve was removed and cleaned, and has been replaced since because of a reoccurring technical problem identified by our revised procedure. We're able to see that this valve was not always working properly, was activating, putting some quantity of diluting oxygen in our supply line. So lessons learned with this case is technical problems can occur at any time. They can impact both patient and staff. Inside attendants should not hesitate to report rapidly any symptoms after pressurization. Denial, as we can see in divers, seems to also occur in inside attendants. Elaborate monitoring procedures can help prevent accidents by revising our procedure. We're now probably more safe for our staff. And also, don't be scared to share your mishap. It can prevent accidents in other centers.